Thank you, everyone, and I want to thank the organizers for giving me a chance to present on a topic that I've done work on for many years. Before I joined Africa CDC, which I've been here for a year, I spent 15 years of my professional life with Elizabeth Glaser Pediatric AIDS Foundation. And actually, my card still says Elizabeth Glaser, so I guess, I'm still part of it. And so while at EdPAF, I did a lot of work on HIV and TB at programmatic level, and now I'm doing a lot of work more at continental and policy level. And so it's going to be a mix of some of the work that we do. No conflicts to declare. So just a quick mention what Africa CDC does. So we are a health institution for Africa Union, and our work is to support health initiatives for member states. So we work with 55 AU member states with the sole objective of strengthening their capacity for public health institutions to detect, prevent, and control and respond to many other diseases. And so HIV and TB is part of the work we do, but we also do a lot of surveillance, lab strengthening, emergency response, NTDs, and many other things. And so this is just to highlight some of the work. I feel like, is it that I'm short? Or maybe I should look at this instead of that.
You can stay on the side.
Oh, perfect. Yes, this is better. Yeah, because I felt like I was training and I wasn't able to see. Thank you. And so before I go, what you see on the left is something that I saw in the media recently, and this was done by somebody who does work in diagnostics, and they're saying TB, it's not over yet, even though it should be. So if you think about it, many decades dealing with TB, it should be over, but it's not. And this particular writer was focusing their work on the dearth of diagnostic work around TB. But if you think about on the other side, we have two epidemics and one mission. So we have HIV and TB. And so as we sit in this HIV and Women workshop, we need to think about what about the other co-infections. And this session is just about that. And early this morning, we were talking about, does ARVs cause hypertension? So what about ARVs in someone with HIV and TB? What then do you have? So things, just to think around it as we discuss during these 2 days on some of these relevant issues. And so a quick introduction, really nothing new to this audience here, but thinking about HIV and TB co-infection means the individual simultaneously has both HIV and TB, and really it can, either of the diseases can exacerbate progression to both diseases. And I must apologize, my references are at the bottom of the slide. They were formatted, so they are in the notes section. So when you get these slides, you'll be able to see that. I apologize about that. And so the co-infection can exacerbate progression of both diseases, leading to more severe health complications. And studies have shown that people living with HIV are more likely than others to become sick with HIV, and it remains one of the leading causes of death among people with HIV, especially without treatment. And there's also the other element of latent TB infection. And so when you have HIV and you have latent TB infection, you have a risk of progressing to TB disease, and this risk is even more significant among pregnant women. So this is really global data, again from WHO TB report. In 2022, 7.5 million were newly diagnosed, and this newly diagnosed refers to notified cases, as opposed to 10.6 million that were incident cases. So you can see there's a gap in terms of the reporting and notification of those who have TB. And there was 1.3 million deaths caused by TB, and among these deaths, around 167 were people living with HIV, and of the 1.3 million, more than 400,000 were in Africa. Still on the data, if you think about those who developed TB in 2022, 33% were women, 55% were men, and 12% were children, and more than 400,000 people developed multi-drug resistance TB or rifampicin resistance TB. And the success rate has been different, especially it's better for those with drug-susceptible TB at 88%, but people with multi-drug resistance TB, the success rate is lower at 63%. So like I mentioned, some of the challenges for TB remains delayed diagnosis, limited access to new tools, technologies, and ongoing threat of multi-drug disease-resistant TB. And if you think about that story, that bullet, HIV is the same. We have delayed diagnosis. There's limited access to tools, need for technologies, and resistance. So again, two diseases with very similar challenges that that perhaps should be considered, side to side or jointly, especially if you have a patient who has both. And like I mentioned, among pregnant women living with HIV, concurrent TB infection increases their risk of complications, for example, preeclampsia, low birth weight, and indeed perinatal transmission of HIV. And so when you think about TB, HIV co-infection, this table is from WHO, and it tries to highlight the high burden countries for both TB. So the TB is the red. For the HIV-associated TB is the one in the orange, not orange, that's yellow. So when you see there are many countries, and a lot of those are in sub-Saharan Africa, and the blue is around MDR. So this shows you where the burden is and where the focus should be on when it comes to this. In terms of the global targets, and I'm just going to focus on this one here. Is this the pointer? It's not working. Okay. So if you think about the global targets, the one I want to focus on is the one at the top. So the target was to have, oh, okay. All right, let me just leave that. So the target, oh, I need to point you this way? It doesn't really work, okay. So thinking about people living with HIV, because we are talking about HIV and TB, the target was to have at least 6 million treated people living with HIV, and you can see there's been an overshoot between 2018 and 2022. There's discussion around that. Is it the data? Is it that we are under targeting, or what could be the challenge? But when you think about TB deaths, and again, apologies, this is a busy slide, but just to say that there were more than 1.3 million deaths, like I mentioned, and the deaths among people living with HIV over the years have been, going down, while the deaths from people who don't have HIV actually are either stagnant or going higher. So there's a lot to be learned in terms of this. The TB mortality is thought to have been impacted by the pandemic, and so that could have caused the higher numbers. And again, the percentages show the number of women, children, and men that are affected by TB. And studies of maternal mortality have reported that there's a threefold increase in the relative risk of death in mothers living with HIV and TB as compared to mothers without HIV and TB. So really a significant effect on the women as well. This is a slide that talks about the trends in TB deaths, both HIV negative people and people with HIV. As I've said, the HIV negative are more, but they are the majority, and so the numbers, this is not surprising. But the trend in the people with HIV and the deaths is remarkable, because the trend is going downwards, while the deaths among people with TB and HIV negative have either gone upwards or really decreasing very slowly. And this is thought to have been affected by COVID, but also other efforts around the TB work as well. So I think this is a repeat slide showing again the HIV deaths, the TB deaths in HIV negative people, and TB deaths in people with HIV is lower, and the trend is going down. And so that's a remarkable finding from UNAIDS data, but it's different from many other countries. So if you think about the Africa region, there's been a lot of effort, so the death trends are going lower, but in the Americas, Southeast Asia, Mediterranean, it's going higher, and this has to do with not just COVID, but also efforts around diagnosis, access to treatment, which really, when you think about Africa region, is where you'd expect to have lesser access for treatment. And so when you think about HIV and TB, people living with HIV have 15 to 22 times more likely to develop TB than those without. And so when we have efforts around HIV, there needs to be efforts on TB as well. And a study in South Africa found that TB disease among pregnant women living with HIV was 10 times higher than among pregnant women without HIV. And for those with HIV, the risk of extrapulmonary TB is often higher, usually lymph nodes, disseminated, or even pericardial TB, and so there's a need to ensure that there's proper diagnosis when it comes to this. In terms of treatment, and again, when I started, we talked about earlier around the effects of ARVs and hypertension for people with HIV, but there's also the effect of TB treatment for people with HIV, and it's recommended that there should be early treatment among those people with both TB and HIV. Previously, there was concerns around the as TB-associated immune reconstitution inflammatory syndrome, but now the guidelines guide that there should be immediate treatment with TB as soon as somebody with HIV is diagnosed. And the regimens are changing. We have the 6-month regimen. They're now going low, and so access, of course, is still a challenge, but that's something that has been improved over time. And as well as patients with multi-drug resistance TB also should be clinically assessed and put on treatment as well. Now, when you think about how to diagnose TB in patients with HIV, so again, this is a cascade that was done by a team from Tanzania. And so this is a care cascade that should be done in all HIV care and treatment clinics. So it starts with the person who has HIV enrolled in treatment, and then they are screened for TB, and this screening should be done at every clinic visit. So then you have a loss of those who are not screened, and then among those who are screened, if they are screened positive, then they are diagnosed further to see if they have TB. If they have TB, they are treated. But if they are screened negative, then they are screened for TB prevention therapy, and the cascade goes along. So you can see that there are many areas of losses, and so this is data that is tracked, that should be tracked in every care center, to ensure that all patients with HIV get screening for HIV at every visit, and depending on the screening, they are either put on treatment or assessed to get TB prevention therapy so that you improve the outcomes. And this is data, this is the latest data that I could get from PEPFAR talking about the cascade. So again, more than 5 million people living with HIV on ART were screened for TB, 28,000 new cases detected, and 46,000 on TB treatment. The number is higher than those detected because the 28,000 is newly detected, and so the 46,000 means that there are more who were detected that year, the previous year, and were not put on treatment. And the cascade goes on to talk about among the 5 million, 1.3 million were initiated on TB preventive therapy after being screened and found not to have TB, and more than 1 million completed TB preventive therapy. So this is a significant data to review to ensure that there's good quality of care, and everyone who's getting ART is screened, and they can get the treatment that they need. So one of the benefits of treating TB among those patients with HIV, and even those without HIV, is averting death and improving treatment outcome. And so this table highlights the cumulative number of deaths in millions that you get from treating TB, people without HIV, but the most important one I wanted to highlight was people with HIV in the middle. So more than 4 million deaths are averted in the African region when you treat patients with TB and ARV together, and looking at both globally and the African region. So there is a lot of benefit in ensuring that patients with HIV are screened, are assessed, and if they have TB, they receive treatment and supported to complete treatment in order to avert the deaths. So when you talk about remember we talked about the cascade and the cascade for diagnosis TB among patients with HIV, and this is PEPFAR data that looks at the estimated number of missed TB diagnoses among people with HIV, and also the estimated TB HIV deaths. So you can see the graph rose in 2020. This is thought because of COVID, and in 2021 this has improved. And like I said, the TB deaths have a lower projection downwards based on the global data as well. And so when you think about HIV and TB co-infections, when I was working on these slides, I had a lot of areas that perhaps I could have focused on, but I want to summarize some of the clinical issues to worry about on this slide and a subsequent one. So when you're treating for HIV and TB, remember there's the overlapping toxicities. So there's toxicity from HIV treatment and the toxicity from TB treatment, and toxicity from any other infection they may have, be it diabetes, hypertension, or any infection. And HIV-TB co-infection presents then an increased risk as well for kidney-related morbidity and mortality, and the risk is between 6 and 15%. And so when you think about the toxicities, this may lead to, this is potential for loss of the antiviral efficacy. So as you know, there are some of the TB drugs that are metabolized through the same pathways as the HIV drugs, and so with that interaction, you may lose the antiviral efficacy and develop viral resistance. And so this is something important to look out for when you have patients who have both HIV and TB. There's there's proven pharmacokinetic interactions with the different ART classes. You know, when you combine the anti-TB drugs, be it for drug sensitive or drug TB, and one particular one is rifampicin, which if you compare the guidelines when you use rifampicin with dolutegravir, it affects the bioavailability, and hence there's a need to double the dose while they are on rifampicin. There's also the risk of drug-induced liver injury, which is a more serious adverse reaction when you're using anti-TB drugs. And especially for pregnant women living with HIV, they're especially at high risk of having the LTBI, the latent TB, progressing to TB disease with immunologic suppression related to pregnancy. And so this is something that should be looked out for to ensure that the pregnant women living with HIV are screened for TB and they are given TB prevention therapy as much as possible. The other one I wanted to highlight is management of drug-resistant TB in patients with HIV co-infection. So again, the drug-resistant drugs with HIV, just like drug-sensitive TB, will present a number of additional challenges. There are shared toxicities between the TB drugs, resistant TB drugs, and the HIV drugs. But if one of the common drugs is bedaquiline, and if you compare the bedaquiline with the INSTI, there's not much studied, but clinically it's found, you know, the relevant DDIs are not expected, and so the guidance is that the bedaquiline and the INSTI can be co-administered without dose adjustments. However, when you think about lopinavir and bedaquiline, this now increases the dose. It affects the bioavailability, and so the advice is to avoid concomitant use. And so the potential for increased drug toxicity due to, you know, the drug-to-drug interaction is there, but as well underlying HIV-related organ disease, such as nephropathy from HIV or TB of the kidney. Like I mentioned, the DDIs, the iris, and other manifestations of extrapulmonary TB. And mortality with multi-drug resistant TB has been found to be higher among the HIV-positive patients, but the adverse events among multi-drug resistant TB and HIV-positive patients is not thought to be much higher than multi-drug disease and HIV-negative. So it's the mortality that's thought to be a bit higher, but the adverse events from the studies I saw is not thought to be that much higher as we would imagine. So some of the challenges that are faced across, you know, when you think about HIV and TB co-infection, and some of these I've already alluded to. We talked about stigma and discrimination this morning. This is something that is still a challenge. For years, when somebody has TB, they're ashamed because it is assumed they have HIV, and TB is seen as a disease of stigma. Of course, there's the lack of access to basic resources, drug resistance, you know, as the emergence of drug-resistant strains of TB and HIV is a growing concern. There is limited funding for research and treatment programs, as well as the co-infection will surmount the challenges that are there. But however, all is not lost. There are a lot of innovative approaches that have been implemented in Africa to address this. One of those is, you know, the multi-drug resistance therapy. So as you give the multi-drug resistance prescription of TB drugs, you give the same for HIV. There's online appointments with physicians, and in many of our programs, there's as well the use of remote clinicians to read and translate chest X-rays from remote locations. There's use of shorter versions, preventive therapies. There's the destigmatization campaigns as well. And now there's significant growth in the research. And when you think about the technological advancements, there are many. We now have improved diagnostic tools, such as the Gene Expert. I think the challenge is access for many countries, and this is something we are working with at Africa CDC, so that we work with member states and the ministers of health to embrace some of these technologies in their countries. There's the point of care testing. There's the long-acting injectable therapies. That is a topic that is dear to Natella, I know. So again, perhaps patients who have TB and HIV can benefit from the injectables. We have advanced adherence monitoring technologies that have worked for HIV and can work for TB as well. And like I mentioned, there's telemedicine platforms that connects healthcare providers with expertise in various areas and the mobile health applications. So there are many technological advances. The advances at various levels when you think about where they are in Africa, but really a lot to learn from the various teams. So again, in summary, TB remains a leading cause of death among people living with HIV. People living with HIV have up to 20 times the high risk of developing TB. It's 10 times among pregnant women. Screening should be offered for all people living with HIV and linking them to treatment, both drug sensitive or drug resistance. And people living with HIV must also, get TB prevention therapy. Like I mentioned, pregnant women living with HIV are at significant risk for latent TB infection, and as well as, the risk of preeclampsia, low birth weight. And so it's important to ensure that they are screened and this is managed. I thank you.